Thank you, Ajay, for conceptualizing this widely appreciated course year after year. Uh, my job is to speak about PDR and its complications. You see, India today is home to the largest number of diabetics on the earth. There is 101 million, which is surpassed. A couple of months back, we used to talk of 77 million diabetics, but today we are 101 million diabetics. Nobody, no ophthalmologist can escape not seeing diabetic patients and we all know the blindness, the moderate visual loss in diabetes because of maculopathy, and PDR causes, or the sequelae of PDR, not PDR, but sequelae causes severe visual loss. As was nicely emphasized by Dr. Bhuvan that in PDR, a good scatter laser photocoagulation has saved so many eyes. You see, decades and decades back, we used to do laser, and those patients are still maintaining 6/6 vision. Anti-VEGFs are trying to poke in everywhere actually, in all stages of diabetic retinopathy, be it PDR, be it diabetic retinopathy. But the issue with anti-VEGF is repeated injections are required. Cost is another issue. Multiple visits is another issue. What I would recommend is whenever multiple injections are required, it's better to that you go in for early vitrectomy rather than keep giving injections in the eye. You see, this was the study, protocol S study, which tried to shove in injections even in PDR. And what this study showed, even 5-year follow-up is available, that is non-inferior to and a reasonable alternative. But the problem is of multiple injections. This is how I use in PDR injections. You see, a patient who has massive fronts, big fronts, but good vision. This patient, you may inject ranibizumab, but ultimately laser has to be done. The other patient, one-eyed patient, who has a lot of fronts at the posterior pole. Like Bhuvan was saying that, laser is still the mainstay of treatment. So here, one injection and then after laser. So now I will be touching something about vitreous surgery in diabetics. At the outset, all membranes do not require surgery. Nasal TRD and macula not being threatened, you can easily observe. Believe me, diabetic vitrectomies are one of the most complicated vitrectomies you face. So aim should be not to do any harm to these patients. So this is one patient who has been under follow-up for a long time. Since the macula is good, 6/12, easily follow up. This is one patient who requires surgery, but somebody gave injection in the eye, and once patient has massive TRD with rubiosis, then you easily refer it for VR surgery. So indication of vitreous surgery is no longer that non-resolving vitreous hemorrhage. Vitreous hemorrhage is one of the indication, but today most of the indications are evolving about macular TRDs or combined detachments, or even sometimes non-responsive macular edema, tractional macular edema. So I'll just begin with showing one or two videos with some kind of tips. This is a non-resolving vitreous hemorrhage patient, but multiple recurrences, 3 recurrences in a year in this young lady, IDDM lady, bilateral vitreous hemorrhage. So after the vitrectomy, you see this was the source of vitreous hemorrhage, a massive fibrovascular front on the disc. One should be very careful that do not taper it down to the disc, otherwise if it bleeds, you will have a tough time. So then we shift to the rest of the retina, do as much peripheral dissection as possible. But the reason I'm showing this video is that the surgery took not 10 minutes. The macula was very good, the disc was very good, potential of vision seems to be very good, 6/6 kind of stuff. But 25 minutes I had spent lasering this eye. 10 minutes surgery, 25 minutes laser. And I would definitely want to emphasize that laser, once you do not do tuck here and there, but follow the vessels. Then you will not have any skip areas. And this laser is done all across. This is that, line drawn here so as not to go inside the posterior pole. So as you see, how much time is being spent on laser, because I still believe ultimately a good laser will ultimately save this eyes, not injections in this particular patient. So this is the scene at the end of surgery, that I said 10 minutes surgery but 25 minutes of laser job, and this is how a good scatter laser photo will. So in this patient, since there was not much detachment, nothing, so we just did an airflow exchange and came out, no gas or no oil. So this was the post-op result in the right eye, and even in the left eye we had good result. So this is another video where this is again a diabetic. In a diabetic retina, the key step is to identify the hyaloid. Once you identify the hyaloid, then I think half the job is done. So here we have identify the hyaloid, and once you make a hole in the hyaloid, the loose blood from the retrohyaloid will, you can suck it out or aspirate it out, or maybe passively it will come out. So once we create a hole in the hyaloid like is shown here, this loose blood is being passively taken out, and then you address the membranes, various membranes on the surface of retina, and see how much adherent they are. More adherent means they may require bimanual surgery or some precautions. Also, there may be some iatrogenic ooze during the surgery. You should pay attention to this iatrogenic ooze immediately, otherwise this will form a membrane which will become very difficult to take it out. So with the help of back flush, take out this fresh blood from the surface of retina, and the loose membranes can easily be pulled up. But tough membranes you can't pull. So in diabetic membrane, don't pull too much, because if you pull too much, two things can happen. One is break formation, other is bleeding. So we should avoid all these complications in diabetic vitrectomy. Do not pull too much. So this is the scene at the end of surgery. You have this maculopathy and florid PDR. So we did airflow exchange and came out. Other indication of MIVS in diabetes is a non-responsive or a tractional kind of macular edema. So here again we do a combined surgery, cataract plus vitrectomy. Here the job is much simpler because you just have to take out the hyaloid and a associated epiretinal membrane. So this patient we did tricord assisted removal of the hyaloid, and since media was getting hazier, you could see this posterior subclavian cataract. Called in the cataract surgeon who did a very good cataract surgery, and then we go back again. So I stain these membranes with the help of trypan blue, the epiretinal membranes, and then identify the edge with the help of this old MVR blade. Old MVR blade will always have a small bend or a micro pick. Then you identify this membrane, because the key step here is to identify this plane. Once the plane is identified, then you take hold of Eckart forceps and take out this membrane. And after that you can stain with BBG dye, because BBG dye will selectively stain the ILM, and the removal of ILM ensures that all the preretinal membranes have been taken out, and there is some data available which shows that if you remove ILM, the post-operative formation of further membranes gets reduced. So this was the last ILM removal. This was another diabetic patient here. In contrast to the first two patients, this cord was very tough, and you had to take a calculated decision because it is in the unimportant area in the inferior nasal part. Fortunately for me, this with suction, this did came out, but I did not clean the entire this thing because of bleeding quite a bit. We did diathermy to this and left it, but fortunately this patient recovered 6/12 vision. And after you have dissected, then you do diathermy, because no diabetic vitrectomy you can start without the availability of diathermy. Most important instrument at that time is diathermy, because repeated rising of IOP has the negative effect of causing damage to the optic nerve. Remember, the optic nerve is already damaged in these patients. And this is the last video here where we did this dissection. Most of the areas we cleared, but in this left eye, the nasal part of the membrane we could not. So therefore, what sometimes we do is that we shift the ports. So this was inaccessible. So we shifted the infrotemporal, that is the infusion port, to upper nasal, and also shifted the operating chair, so that what was nasally now becomes inferior for me, and then accessibility improves. Then you can remove this membrane in a lesser possible time with less of complication. And this same membrane now it is inferior, and after we have done this, we come back to the original position and do the rest of the vitrectomy. This was a young IDDM patient who had combined detachment, combined REG plus TRD. As I said, the key step is to identify the hyaloid. Here, after 15 minutes of struggle, hyaloid could not be identified. So therefore, this you see there is a break here and there is a bullous detachment here also. So this was the frond on the optic nerve head. So with gentle lifting of this frond, very gentle, don't pull it too much. Gentle lifting creates a space where you can then insinuate your 25 gauge cutter beneath as is shown here, so that now you have island formation. So once this is cut, then you move along the various folds of the retina and take this along these various folds and use multiple instruments to do a lot of segmentation. No peeling should be done in such patients because you will land up in multiple problems of break formation as well as bleeding. So two B's have to be avoided, breaks and bleeding as far as possible should be avoided. So after this was done, then just to make a judgment what's happening now, injected a PFCL bubble to stabilize. You see multiple islands having been created, segmentation done. After that, shifted to a bimanual surgery. So same patient, insert this 25 gauge chandelier here now. Believe me, bimanual surgery even in this era of 27 gauge or 30 gauge has a definite place, because I feel bimanual surgery adds precision. You can lift up with one hand and identify the fibrovascular attachment and then cut it with the help of curved scissors. Curved scissors is one of the most useful instrument in a diabetic vitrectomy. Or you can have, sometimes diathermy or sometimes cutter also. But I find curved scissors to be the most useful instrument. And if you're careful, believe me, bleeding and breaks are reduced to minimum by this bimanual procedure. So we'll just make it fast forward. So this is the same patient, curved scissors being used to identify. You have to be very, very patient in such patient. You can't rush, because therefore I normally keep a diabetic vitrectomy at the last case of surgery, not at the first. If you keep first, rest of the cases may get cancelled otherwise. So this was another patient, diabetic. The reason I am showing this patient is that, again, hyaloid, plane may be difficult. So here, instead of using old MVR blade, we use a sharp MVR blade and incise this hyaloid. It looks quite riskier, but believe me, macula is way down, because you have to study the pre-operative OCT as well as ultrasound. And then once this has been cut, then you do the rest of the surgery with the help of segmentation and scissors, as I had shown in the previous video. So thus to conclude, bimanual surgery, as I said, has a place even in the era of 27 gauge or 30 gauge, because it adds precision and less of complications and better hemostasis also. So this is that lady whom I had shown pre-op the video, left eye as well as right eye. There are a couple of more patients. You see, ultimately visual recovery will depend on the health of macula and the optic nerve status. So therefore I am not very keen to always raise the bottle height to 60 millimeter for multiple times. Once a while you can do it. This is another patient. So thanks to the health of macula and optic nerve, patient got 6/6 in both the eyes. So thus to conclude, pre-op assessment is very important. Pre-op anti-VEGFs you can give, especially if the fronds are angry looking or red colored, and they should be given at least 1 or 3 days before the surgery. And also inquire the history of blood thinners, because a lot of these patients are cardiac patients and they are on multiple blood thinners. So I would like to avoid, because surgery sometimes may become messy. So it's not a simple procedure, because PVD is difficult. There are multiple tenacious vascular attachments. Because they're vascular, they bleed, and because they're tenacious, you tend to have break formation. So the solution always is work very slowly. Do not pull too much. Do more of segmentation. Patience is the ultimate key, and newer probes with faster cutting rate, with port closer to the tip, does make the job much easier, and bimanual surgery does help in a lot of these patients who have tenacious attachments. Thank you very much for your kind attention.
Thanks, Dr. Lalit, for those wonderful tips. You have those one-liners, those two words, which actually stay in your mind, which are very